So hello friends, welcome back to my channel Medicine of 101. Today we'll talk about Myasthenia Gravis. So here's the part 1. In the second part we'll talk about basically the pathophysiology. Today I'll give you the basics, or you can say the general idea about the Myasthenia Gravis. Okay. So as you know that this is the disease where we'll get the problem at the level of neuromuscular junction. So we'll get neuromuscular junctional disorder, right? Write it over here. The neuromuscular junctional disorder. What are the thing we will get over in these cases? Let's talk about the normal thing. What we will get under normal physiological circumstances? What are the thing we will get over here? Now, as we know, for example, is a piece of the spinal cord over here, and is the alpha motor neuron. Is the alpha motor neurons, right? And as we know, within the basic, within this whole part, that means over here we can say in terms of the presynaptic membrane over here, we will get the depositions of neurotransmitter, for example, the acetylcholine over here. Okay, let's go in this way, guys. Now, how we are getting the acetylcholine? As we know, through the diets, we are taking we are getting the cholines, right? Through the diets, we are getting the choline, and there is the presence of the special types of the transporter by which the choline that will be taken within this figure, within this presynaptic membrane over here. Okay, and we are getting the choline, and along with that we will get the acetate from the mitochondria. So from the mitochondria we will get the acetate, and we will get the choline from the external source through the diet. Ultimately we will get the production of acetylcholine. Okay, now as we know that whenever the nerve impulse that, or we can say the wave of depolarizations, the nerve impulse, or we can say the wave of depolarization that will come from these portions, that is from the central nervous systems to these portions, at that time, just try to understand from here, whenever the wave of depolarizations that will come over here, or we can say the nerve impulse that will reach over here, at that time, as we know, within these portions, the voltage sensitive, or you can say the sodium channel that will open. Whenever the nerve impulse will come over here, that will stimulate these portions. As a result, we will get the opening of sodium channel. So whenever we will get the opening of the sodium channel first. Now see, before reaching of the sodium ion, where before just influx of the cations within this presynaptic membrane, it was having what are the thing we got over here, the acetylcholine. We got over that was stored within the vesicles. Okay. Now, what are the thing we'll get over here? This sodium that will neutralize the negative potentials. After that, we'll see whenever the sodium that will reach over here, that can stimulate the opening of voltage sensitive calcium channel. So here we'll get the opening of voltage sensitive calcium channel. So here we are getting the opening of voltage sensitive calcium channel. And see, within the vesicles we will get the certain types of the protein along with the vesicles. What are the proteins we will get? See, in these cases we will get the many kinds of the proteins, but I am mentioning some of them. So we are getting this protein. This is known as synaptobrevin. In the same way we will get also over here synaptobrevin. Okay, this protein they are known as synaptobrevin. What did I say you up to now? That at first we will get whenever the nerve impulse that will reach up to this much portion, then we will get the opening of the sodium channels. So whenever the sodium that will be accumulated within this presynaptic membrane, after that we will get the opening of the voltage sensitive calcium channels. So whenever the calcium, we will get the influx of calcium. What are the things we are going to see right now? See, this calcium that will get bound along with one protein, this along with another protein that is getting fused along with the membrane. Now we will get another kind of the protein. For example, let me show with this color. We get another kind of the proteins. This is known as syntaxin. The syntaxins are having the two, we can say that poles that are getting fused, or they are just we can say over here towards each other. Now just to remove these two portions from each other, the calcium will come on action, the calcium that will reach over here, and as a result this calcium that will get bound along with these regions in the same way along with these regions. Now whenever the calcium they will get bound along with these two structures, this calcium they will repel each other. The calcium they will repel each other. As a result, we will see these two hooks like structures, they will be separated from each other. So ultimately we will get the structures. Okay, that will be in this way. So right now the calcium they will also get bound along with the synaptobrevin, this protein. This is the synaptobrevin. So you can write it over here. This is known as synaptobrevin. Synaptobrevin. Okay. Now what the calcium will do, this calcium that will get attached along with the synaptobrevin and it will push towards the syntaxin protein. Now the calcium that will push this whole structure and that will get fused along with the syntaxins. After that we will see this vesicle that will get fused along with the membrane, and ultimately we will see this vesicle that will secrete what? The acetylcholine. That will release the acetylcholine. Now, what did I say you up to this much? At first I say whenever the nerve impulse that will, for example, I am talking over here in terms of the alpha motor neurons. Okay. So whenever the nerve impulse is reaching out to the presynaptic membrane, at first we will get the opening of the sodium channel. So whenever the sodium influx will get over here, as a result we will get the opening of the voltage sensitive calcium channels. Now the calcium that will go where? That will just come to near the syntaxins protein, and it will just cause the repulsions of these two hook-like structures that is present on the syntaxin protein. And along with the calcium that will also do, that will take these whole vesicles and it will help the vesicles to get fused along with the membrane. After that we will get the releasing of the acetylcholine from the vesicles. Okay. Okay. Now in the next part, okay, let's draw it over here. As we know, this is the motor end plate. This is the motor, or you can say the muscles. Okay, we can write it over normally. It will be easier for you. Muscles. That means we can say is the sarcolemma. Now see, these are the structures. These are the crest-like structures. These are the crest-like structures. Now the crest-like structures will get the presence of acetylcholine receptors. On the crest-like structures will get the presence of acetylcholine receptors. Okay, if you see the structures of the acetylcholine over here, try to understand. The pentameric. Okay, the structures for the acetylcholine. Now try to understand from this figure. Hope it will be clear for you. Now this 1 is the 2, 3, 4, 5 for example. Now within these pentameric structures, in these two regions, what? You can see in these two regions, the acetylcholine that can get bound. Okay, the acetylcholine that will get bound. In the same way, the acetylcholine will get bound over here also. Now, see, whenever the acetylcholine that will get bound along with these sites in the receptors, after that we will get the influx of the cation. Here we will get the influx of the cation. Whenever they will get bound along with these structures, we will get the influx of the cation where within the muscles. Okay, we will get the cationic influx. So we will get the cationic influx. Okay, cationic influx. Now before happening all these things, this motor end plate, we can see this muscles was having a certain types of the resting membrane potentials. For example, I am just taking the resting membrane potential, it was around -90 millivolt. Before reaching this cationic, before we are getting the cationic influx, for example, the resting membrane potential that was around -90 millivolt. Okay. Now whenever we will get the cation that will reach over here, it will neutralize the resting membrane potential and it will take the resting membrane potential towards the threshold potential. For example, I am just taking over here -40 or 40 millivolt. Now the potentials we are getting over here, we are just talking in terms of the resting membrane potential, that is known as motor end plate potential. Okay, motor end plate potential. Okay, so see, we got up to now that the resting membrane potential that was taken from the -90 millivolt to the threshold potentials, and whenever we are getting that the resting membrane potential that is getting towards the water threshold potentials, at that time we'll see the opening of voltage sensitive calcium channels. At that time, whenever we'll see the resting membrane potential that will reach up to threshold potential, at that time we'll see there will be opening of the voltage sensitive calcium channel. Okay, for example, I'm just showing over here, guys. Okay, so we'll get the opening of voltage sensitive calcium channel, and as you know, this calcium that will go within the endoplasmic reticulum. Within the endoplasmic reticulum, there is a receptor for it, and it will stimulate the endoplasmic reticulum. As a result, again we will get the releasing of more amount of the calcium from the endoplasmic reticulum within the cytoplasm. The concentration of the calcium that will be increased. Ultimately, as we know, this calcium that will go towards the what? Actin and myosin filaments, right? And ultimately we will get the muscular contraction. It's a normal thing, as you know, under normal physiological circumstances. Now, try to understand from here what type of the thing we will get in terms of the myasthenia gravis. Okay, before that, see, in these cases, the myasthenia gravis is the neuromuscular junctional disorder that can be found for productions of the autoantibodies. Here we can get the production of autoantibodies, the first thing. Autoantibodies. What type of the autoantibodies we will get over here? In this case, you see, whenever we are getting the autoantibodies, in 85% of the cases, we will get the productions of autoantibodies, okay, against these acetylcholine receptors. Acetylcholine or receptor. Okay. Now try to understand, whenever we are talking in this way that we are getting the autoantibodies against the acetylcholine receptors, so definitely try to understand from here, whenever we get the production of autoantibodies, the antibody that will come over here, and as you know, I'll talk about these things later, but I'm just saying very briefly. Okay, whenever the antibody that will get attached along with the acetylcholine receptors, as you know, within the antibody there is the Fc regions, and whenever the Fc regions of the antibody that will be activated, that will also act certain types of the complementary proteins. We know in terms of then the classical pathway, if we just talk about over here, we'll get C1, we'll get what? C4 first, then we'll get C2, then we'll get C3b, then we'll get the C5b, then we'll get C6, C7, C8 and C9. And as you know, from the C5b to C9, that will form the membrane attack complex. So this membrane attack complex that will come over here and that will form the holes along with the body structure of the sarcolemma. So ultimately we will see the transmissions of the nerve impulse from here to here, it will be okay. But further, whenever we will get that these acetylcholine receptors, whenever they will be inhibited, as a result, whatever the thing, there will be productions of the acetylcholine, but there will be no work of the acetylcholine because the receptors are already blocked. Now, whenever the acetylcholine are released over here, try to understand this acetylcholine that will be not longer. Why? If the acetylcholine is for the longer durations, then we will get the for longer muscular contractions. Okay, that's the presence of one type of the enzyme that will destroy the acetylcholine within the synapses or whatever within the synaptic. Now, what type of the enzymes is over here? That is known as acetylcholine storage. Acetylcholine storage. Okay, this acetylcholine storage that will destroy the acetylcholine from here. Okay, that's why we will not get for the longer durations in terms of muscular contraction. Is that not okay? Now, what about the other disease? I just mentioned about the 85% of the cases where we will get the productions of the autoantibody in terms of the acetylcholine receptors, and in the 50% cases. Okay, let's talk about these things here. See, in 50% cases, we will get the productions of the autoantibodies against another proteins. At first, I will tell about the proteins, then I will go in details. Now, see, as we are getting over here that basically the acetylcholine receptors, that is also nicotinic, this receptor, because the nicotine also can bound along with these structures. The acetylcholine as well as the nicotine. Okay, that's why it is also known as nicotinic receptor. Now, there is presence of another kind of the channels over here, another kind of the protein, rather we can say. This is known as Musk protein. This is known as Musk protein. What is the full form of the Musk? That is known as muscle specific tyrosine kinase. Tyrosine kinase. Now, what its functions? Its function is for the regulations of the concentrations of acetylcholine receptors on the sarcolemma. So, as the functions of the muscle specific tyrosine kinase, actually it's one type of the enzymes we can say over here. So, its main functions are regulation of acetylcholine or receptors concentration on sarcolemma. That means on these structures, okay, on the crest. Now, these proteins, whenever it will just send the signals, within the nucleus, the certain types of the genes that will be activated, and those genes that will form the the receptors for the acetylcholine. But in the 50% of the cases, we get the productions of the autoantibodies against this Musk protein. So here we get the autoantibody against Musk protein. So whenever the Musk proteins will be inhibited, try to understand there will be not enough productions of the acetylcholine. So there will be no use of the acetylcholine receptors. The acetylcholine receptors ultimately will get, there will be no proper muscular contractions. Okay. What are the other regions? As far as the autoantibody is concerned, we will get in this way that 85% of the cases will get in terms of the where we will get the autoantibodies against the acetylcholine receptors, and 15% of the cases where we will get the productions of the autoantibodies against the Musk protein. Now the same just like the Myasthenia Gravis, we will get another kind of the disease that is known as Lambert-Eaton syndrome. So what type of thing we will get over here in terms of the Lambert-Eaton syndrome? Okay, so in terms of the Lambert-Eaton syndrome, in these cases we will get the autoantibodies, but against this voltage sensitive calcium channel. That means in the specific way we can say against presynaptic voltage sensitive calcium channel. So here we get the autoantibodies against presynaptic voltage sensitive calcium channel. Now see, whenever we will get the autoantibodies in this case, try to understand, whenever we are getting the autoantibodies, this calcium channel that will be functionless, or we will get the dysfunction of the calcium channel. So whenever we will not get the influx of the calcium, there will be no proper opening of the syntaxin protein. Along with that, we will also see over here this synaptobremin that will be not able to fuse along with the calciums. So there is no chances for the vesicles to get fused along with the membranes, presynaptic membrane, to release the acetylcholine that will get bound along with its receptors that is present within the sarcolemma. Now, what are the other regions over here? Let's talk about those things. Another thing we can get over here that is known as congenital myasthenia gravis. Congenital myasthenia gravis, where we will get the genes, we get the mutation in the genes, in genes are responsible for the production of the different kinds of the protein in terms of the presynaptic membrane proteins, in terms of the synaptic protein, in terms of the postsynaptic protein. So in these cases, in terms of the congenital myasthenia gravis, here we will get the productions of the defective protein, where in terms of the presynaptic protein, in terms of the synaptic proteins, it is also protein in terms of the postsynaptic protein. Okay. Now see, so these are the things. Now the different kinds of the toxins, there are the different kinds of the toxins that can also produce the myasthenia gravis. Especially we have to mention over here in terms of Clostridium botulinum. So Clostridium botulinum, these toxins 1 microgram is enough to produce this type of the effects. Okay, Clostridium, these things. Now what it will do, what is the mechanism of actions for the Clostridium botulinum? Now see, the Clostridium botulinum, it will digest the, this protein. That means we can say over here the synaptobremin protein, this protein. Okay, this is the protein. So it will digest the synaptobremin. So let's write it over clearly. Synaptobremin protein. Whenever it will digest the synaptobremin protein, try to understand this protein will be dysfunction. We will get the dysfunction of the protein. The vesicles will be not able to get fused along with the membrane. So ultimately all these things will be disturbed over here. Another kind of the toxins we can write it over here. That is known as curare. That can also cause the Myasthenia Gravis over here. Basically, you will see in terms of the curare toxins that will block the acetylcholine receptors. And the certain kinds of the drugs, you can remember certain kinds of the drugs that can also cause in some patients the Myasthenia Gravis. The group of the aminoglycosides, especially in terms of the gentamicin. You can remember the tobramycin. Okay, these drugs that can also cause the Myasthenia Gravis. Along with that, you can write it over here, the beta blockers, and you can also remember in terms of the tetracycline and procainamide. What did I say you? Procainamide. Try to understand from here, guys. There are certain kinds of the drugs. Okay, let me check once. Okay. Now what did I say you? There are certain kinds of the drugs. That can cause the Myasthenia Gravis. Okay, in some patients. So what are the drugs? We can see in terms of the group of the drugs. We can see in terms of the aminoglycosides, especially the gentamicins, tobramycins. Okay, in terms of the beta blockers, procainamide, and also the tetracycline. So these are the drugs that can cause also the Myasthenia Gravis. So we can say these drugs are the contraindicators in terms of the Myasthenia Gravis patient. Okay, so what did I say? I am repeating once again. The group of the drugs we can say in terms of the aminoglycosides, the beta blockers, the tetracycline, and the procainamides. So these are the drugs that can cause the Myasthenia Gravis. So these are the contraindicator in terms of the Myasthenia Gravis. Okay. Now we have to keep focus over here that in terms of the Musk. See, what did I say you? The Musk protein. That means the muscle tyrosine kinase. This will regulate the productions, or this will regulate the concentration. The Musk protein that will regulate the concentrations of acetylcholine receptors on the sarcolemma. Now, for whatever the regions, if we see that the Musk protein is dysfunctional, try to understand the concentrations of the acetylcholine receptors on the sarcolemma that will be reduced. So ultimately we will see the acetylcholine that will reach from the presynaptic membrane to the synaptic vessels over here within the synaptic cleft, we can say also over here. But this acetylcholine, they will be not able to fuse along with the receptor, because we are getting over here the productions of the autoantibodies. We are getting the production of autoantibodies against this Musk protein, muscle-specific tyrosine kinase. These are the normal things. The part 1. The next part we will talk about the clinical aspects, what type of things we will get, and how can we manage these patients in terms of the treatment, or what type of tests we are supposed to do if we just suspect any individual who is having Myasthenia Gravis. Now, okay, in terms of the clinical aspects, okay, let's just remember one thing over here. This is the, okay, here we'll get painless weakness. The different muscles, let me on the biceps, the thigh muscles. Is that we'll get the painless weakness over here. Okay. So as far as the part 1 is concerned, we just did complete up to this much. As I said, it's a neuromuscular junctional disorders problem. Okay. Now at first I just mentioned about the under normal physiological circumstances, whenever the nerve impulse that will reach over here, how all these things will happen over here, how the acetylcholine that will be released, and how they will just how they will get on along with the receptors, and what type of functions will get over here. And as far as the different kinds of the etiologies are concerned that can cause the Myasthenia Gravis, we just did mention about the autoantibodies, okay, where we will get in terms of the 85% of the cases we will get the productions of the autoantibodies against the acetylcholine receptors. In 15% of the cases we will get the productions of the autoantibodies against the Musk protein, okay. And I also did mention about this thing that try to understand in terms of the Lambert-Eaton syndrome. Here we get also the in terms of the Lambert-Eaton syndrome. In this case, we will get the productions of the autoantibodies, but not against the Musk protein, not against the acetylcholine receptor, but we will get over here the productions of the autoantibodies against the presynaptic voltage sensitive calcium channel. Presynaptic voltage sensitive calcium channel. If it's clear for you. Okay, so that's all for the part 1. In the next part, we will talk about the more in details about the clinical aspects and the treatment, or you can say the management. Thanks for watching. See you in the next video soon.